Good afternoon, and welcome to podcast number 8 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, and advocates, and anyone else who makes the world a better place through their work. We're here today with Delegate Clarence Lamb in Columbia, Maryland. How you doing today, Dr. Lamb?
Good. Happy to be here.
Awesome. So we want us to start out the conversation talking a little bit about what you've done or what you are currently doing to advance the public interest, either through your work at Hopkins, through your role as a delegate, or any other role you might have.
Sure. So happy to speak about that. I'm one of the few physicians elected to serve in the Maryland General Assembly. There are currently only 3. So, it's interesting to bring both these roles together. So as Jordan mentioned, I am a physician on faculty at the Johns Hopkins Bloomberg School of Public Health, where I'm the program director of a residency program in preventive medicine. Residency is what they do after medical school to specialize in a particular area. And it's a unique perch to have to serve on faculty in kind of a university environment, because we certainly do a lot of research, do a lot of novel work and innovation. We publish papers. You do a lot of grants and administer a lot of programs that make an impact on the public. But oftentimes in academia, you wonder where the connections being made to implementation, or translating that to actual policy, or making sure that someone's actually picking up that publication that people are writing and putting that into effect, putting the best research that's taking place in an academic environment into real life. And so, being able to serve in the legislature is a way of being able to bring those two worlds together, and certainly, find that very rewarding, because there are very few folks in politics who have a background in science. And these days, science has become a more and more, unfortunately, politicized subject area, when really it should be based on sound understanding of what's going on in the environment with people and their human beings and conditions. And so, being able to sit and straddle both worlds allows me to take some of the things that are coming out of the academic environment and put that into practice and into policy in the legislature.
Do you have any examples that you could share from that about research that you've worked on, or at Hopkins or elsewhere, that either Delegate Moorheim, your mentor, helped put into practice, into law prior to your election? Or is there anything that you've worked on or have had colleagues work on in the past that you ended up working on to some extent in the legislature?
Sure. So last year I passed a bill into law that would expand syringe exchange programs, or syringe service programs, throughout the state of Maryland. Syringe service programs are an opportunity for people who are using injection drugs to be able to exchange for clean syringes, so that it reduces the spread of HIV, reduces the spread of hepatitis and other communicable diseases. And it's a long-standing program that the city of Baltimore has had through their health department. They've had special legislation passed back in 1994 to give them the authority to be able to implement a very novel and new program at the time. And so the research actually was done by Hopkins subsequently to that, to show that it really was an effective tool to reduce the spread of HIV and hepatitis in Baltimore. Unfortunately, other jurisdictions in the state have not had that ability to be able to implement a syringe exchange program, because syringes are considered drug paraphernalia, and you actually need a prescription to be able to distribute it. And so what this law that was passed last year did was allow and provide enabling ability to the other counties to start a syringe exchange program if they wanted to. It wasn't a requirement, wasn't a mandate, but really it was an opportunity to provide local health departments with another tool in the toolbox to be able to fight substance abuse, and really as an avenue to get people who have these conditions into treatment. Oftentimes, the criminal justice system becomes the substance abuse treatment venue, and that's really not ideal for us as a community, not ideal for patients. And really, when we want to get people to treatment, and the syringe service programs that are available are another opportunity to do that.
So just to be clear, the syringe exchange program, has that been built upon the needle exchange program that Peter Bielenson introduced when he was health secretary in Baltimore City?
Yes.
Okay, awesome. And have you seen any other jurisdictions take the initiative to take advantage of this law so far?
So there are, I think, other jurisdictions that are certainly interested, because this is really a rising epidemic that we've seen with opioid use and opioid abuse. And so certainly there are a lot of communities that are concerned, to the point where there are even neighboring jurisdictions where there are syringe exchange programs. So we see, for example, in Washington, D.C., there's now a syringe exchange program. And from our data that's been gathered at Hopkins, we know that there are people that are actually Marylanders that have to use the D.C. syringe exchange program because they don't have a local program in their county to be able to use. And there's people from all the way up in Harford County, Cecil County that are traveling down 95 to Baltimore City to use their program because they don't have a local program to use. So this will be a good step in being able to allow other jurisdictions to have one for their local community.
Now, you also mentioned syringes or needles being perceived or being codified in law as drug paraphernalia, and how that's somewhat related to the criminal justice system. Can you talk a little bit about? I think, how would drug paraphernalia and the war on drugs or drug policy, how does that interact with the criminal justice system?
So, syringes are considered drug paraphernalia not in a bad way. They're considered drug paraphernalia just because you need a prescription, just like you need a prescription for certain other devices.
Right.
You can't just walk in and buy a pacemaker. You actually need a prescription or a doctor's order to, get a pacemaker. And so, unfortunately, that does mean that people that do inject drugs have a very difficult time getting them. And so, that's why this law is needed. Do
you suspect that the needles are ever used with illegal drugs?
Yeah, that's what the drug users typically do, is use them with illicit drugs. So it'd be heroin. It could be drugs that are legal, but they've been obtained illegally,
Okay.
right? So it could be fentanyl and OxyContin, oxycodone, cocaine. It could be a whole slew of different opioid and narcotic drugs. And so, most of these folks are injecting with drugs that are, illegally obtained, but that's because they have a medical condition. They have an addiction. And so, linking that back with the criminal justice system, all too often we link mental health and substance abuse into the criminal justice system, and it's really not the ideal venue to try to address those problems. Those are health problems, mental health problems, schizophrenia and suicide disorders and personality disorders. Those are all medical conditions. Substance abuse is an addiction. An addiction is a medical condition, just like OCD, obsessive compulsive disorder, and other mental health conditions. They should be treated just like any other physical condition that you have. And so what these people need are help. What they need is treatment, and what they don't need is to be locked up, because that doesn't solve anything. They become just as addicted in while they're incarcerated. They're not provided opportunities for treatment or for the withdrawal that they have, and they oftentimes leave just as addicted. So, and with a mark on their criminal record, and so then they have a hard time finding a job. They fall back into this addiction. It's a vicious cycle, and so we need to break that cycle. But the first step is to kind of get them into treatment.
So I guess the argument, I guess it must be quite difficult to. I guess there might be opponents. There might have been opponents of the legislation, potentially Republicans, potentially other Democrats, who would have said, well, you're facilitating illegal drug use, but your background in public health says that it actually would reduce the burden to taxpayers if you were to reduce the incidence of communicable diseases through the use of these drugs. So actually, what you're trying to do, in a sense, is be fiscally responsible and socially compassionate. Because these people are going to use the drugs whether or not they have clean needles.
Right.
So if you give them clean needles, you're reducing the incidence of communicable diseases among a population that may be uninsured, who would still necessarily need to be seen in an emergency room should they present, and cost the taxpayer through uncompensated care in the hospital increased costs and cost shifting onto increased premiums because of this uncompensated care. So really what you're doing is being fiscally responsible. Is that kind of the argument you were making, or how were you able to usher this through? How were you able to use your scientific background as a physician and having done clinical research and preventive medicine residency at Hopkins to kind of drive the argument through the legislature?
So that was certainly one argument that we made, and the challenge is, as you know, to get bills passed through the legislature, you need many different arguments, and you need many different good arguments. Well, not every legislation passes because of good arguments, but ideally, if you're going to pass the legislation well and good legislation, you're going to have multiple different good arguments as to why this bill should pass. And that was certainly one argument that we, highlighted to other legislators to convince them that this is, it makes sound fiscal sense in addition to the public health sense. There was a study out of D.C. that looked at this and showed that the D.C. program, I think, costs maybe it costs maybe about $800,000 to run each year. Those are people that are participating in the program, helping exchange the needles themselves. So you're talking less than $1 million each year in DC to run their program, and a few thousand people use it. And when you look at that and compare that to treating one person for HIV over their lifetime, you're talking probably $150,000, $200,000 just in medical bills, drugs, and other expenses, and that person ends up with HIV for the rest of their life. That's a tremendous, cost difference analysis. So when you look at it, if you save 3 people from contracting HIV in DC in 1 year, you've already paid for the program itself.
Is there a correlation between the needle exchange program and a potentially an inverse correlation between the program and incarceration rates?
I don't know if the research is correlated directly to incarceration rates. I know that that it's been shown to be effective in bringing about 20% of people that go through the program into treatment. So I think there's an argument amongst the opponents that say that, well, it's just enabling, it's not really getting them the help that they need, it's just advancing their addiction even further. Well, that's not entirely true, because 1 in 5 that come in through the program and have their needles exchanged actually, do cycle into treatment. Doesn't mean they're always successful in treatment, but, just like when you're quitting smoking, you might need a few times to, get through that addiction successfully. So, this is an opportunity, another tool in the toolbox for them to help them, break that addiction.
And is treatment cheaper than a medium security prison that they may find themselves in if they were arrested for breaking the law?
Treatment is certainly cheaper than, medium security prison or other types of incarceration. So it's a win-win for the state, because it means that you're getting people to the right, venue from which they can help themselves. You're costing less to the state because you're not having to lock someone up, and that's very expensive for a year because you're giving them, room and board and food, etc. And you're also not giving them a criminal record. So, there have been jurisdictions that have created drug courts where people that have addictions and have drug offenses are actually diverted to this, and are diverted straight into treatment programs, so they don't have a blemish on their record when they need to break their addiction to be able to find a job and apply to other positions. That mark isn't on their record. So.
Now, does using these needles actually lead to an increase in drug use, or no?
Using these needles has not been shown to lead to an increase in drug use.
Okay. So
and there are a lot of myths when it comes to syringe exchange programs. There are myths where people have a perception that it will lead to more drug use in the community, that it will lead to syringes sitting out on the streets, that it'll lead to more kids seeing people using drugs, and therefore more kids in schools using drugs. All of that has actually been disproven by the scientific research that's been done. A lot of it done at Hopkins, some other places as well. But those are all myths and actually not based in reality. Those are all perceptions that are inaccurate.
So does the program give free needles to anyone, or must you give a used needle to get a new clean
So you must
needle?
bring in used needles to be able to get used needles.
Okay. Interesting. So it sounds like this kind of effort almost potentially dovetails both with, I guess, distribution of condoms for preventive health measures in terms of reducing the spread of sexually transmitted diseases, but potentially not actually increasing lasciviousness of behavior, and also may dovetail with the medical marijuana legislation that has passed through the legislature, I think, while you've been in office, which was sponsored by your mentor and my mentor, Delegate Dan Morheim. Could you talk to me a little bit about how those three measures have worked together or have had different paths through the legislature as public health measures that ultimately are fiscal responsibility measures?
Yeah, so you cite some good examples. I think they all kind of fall into the broader umbrella of harm reduction.
Mm-hmm.
So harm reduction is a basic public health principle where you are recognizing that people will behave in certain ways, that you can't always change people's behavior, but there are certain measures that you can undertake and interventions that you can put in place that will help reduce the harm of that negative behavior. And so, whether it's condoms to reduce the spread of STDs, because that people will continue to have sex, whether it's giving them clean needles, because certain folks will not be able to successfully be treated for addiction, and this is an opportunity to get them into treatment. There are a lot of harm reduction interventions that we consider in public health. It's challenging when it comes to harm reduction to convince other policymakers, because they will oftentimes view harm reduction as an enabling legislation or enabling policy, which I think is not true. It's another venue to get people to treatment. It's another venue to reduce disease burden. I think it's jumping the gun in a very simplistic view to say that it's just enabling people to continue their bad habits.
And it sounds like what you're really bringing up is one of the greatest challenges facing public health both in America and around the globe, which is what exactly is the return on investment of an investment in public health infrastructure or a public health initiative. For instance, if you chlorinate the water, exactly how many incidences, what would have been the incidence in the following year of cholera had you not cleaned the water? Or if you reduce, smoking, what would have been the incidence in 15 years of lung cancer? How many heart attacks did you stop by reducing cholesterol intake now? Mm-hmm. So it's a lot of public health benefits materialize through non-events after the intervention and often have long-term repercussions. Would you say that is a challenge that you have faced in conveying the benefits of public health?
Yeah, so as a preventive medicine physician, where our goal is to prevent people from getting sick or to implement public health measures that, whether it's clean water or, safeguarding the food system prevents them from getting an illness, it is always really tough, and that's an inherent challenge of public health, to make the argument that we should spend dollars or we should implement a program that people will never see the disease that they would have avoided, right? It's always easy to say, well, we're going to devote dollars to treatment because you can see the person that already has disease, but you can't see the person that doesn't have the disease or was prevented from having that disease and never knew that they would have otherwise gotten it.
Right. Okay. Well, I want to return the conversation back to you in the last few minutes of this podcast. I want to talk a little bit more about Clarence Lamb. Why have you given so much of your life and dedicated so many hours to advancing the public interest? Why have you chosen to run for the legislature? You said you had some interest. You'd already working in medicine. Why did you go into medicine? You said some of medicine helped you, you wanted to get some of that research into policy. But again, it seems like there's an underlying motivation to advance the public interest. Can you speak a little bit about why you went into medicine, why you went in the legislature, and what are some of the common themes there?
Well, I think the common theme is that really in both positions, you are really in a customer service position. You're here to help people, and there are a lot of different ways you can help people. If you're a lawyer, you're helping people through the legal system. If you're a doctor, you're helping them with, conditions and making sure that they stay healthy. And so that dovetails well with, the legislative work, because, as a legislator, you're there to serve people, whether it's getting that pothole fixed or, getting that program to be responsive or to get them the services they really need and deserve. And so, it kind of flows in the same vein. And so, I am interested in policy in general. I'm certainly interested in health policy because that's my background. But, that desire to be able to help people in a broad way, to be able to affect large community change across many different levels and people is where policy comes into play. It's certainly, policy is not for everyone because it's certainly frustrating. It can be frustrating trying to convince colleagues and convince members of the public of the value of certain policies or interventions or programs or funding. But, when it does work out, it's certainly very rewarding. And so just like, being able to see a patient be cured of a condition or seeing that they've been successfully prevented from, having a condition, it's that same sense of satisfaction that you get from knowing that you're able to implement a policy like, syringe service programs that will help people even though you may not know who they are, you may never see them, and they may not even vote for you, but you're able to be there to help people.
Sounds like there's an inherent meaning to having a positive impact on society, on multiple people's lives, even if you're not able to directly receive recognition for having conveyed those benefits onto society. It's just intrinsically worthwhile to advance the public interest for you.
Yeah, absolutely. Yeah, I find that tremendously rewarding. I think, most folks, the vast majority of folks, get into politics, into elected office for good reasons because they want to help people. And I think that comes part and parcel with the position that you're running for, and so to be able to serve in that capacity and also to bring a unique insight as a physician, but also as a legislator to share that experience and knowledge with your colleagues who are dealing with some very important issues, including many of them that are health related, is valuable. We're founded on the principle of a citizen legislature, both in the state and the federal level. And so, be able to bring that insight is important because you need to have a breadth of perspective in those bodies to be able to make sure that you make the best decisions.
Well, thank you. That brings us to the end of episode 8 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, and advocates, and others who advance the public interest through their work. Thank you so much for joining us, and we look forward to seeing you at the next episode.